Hello, welcome to ADAPT NCLEX. And today I want you to focus on one thing and talk to you guys about how to study for NCLEX. I think you may be studying, you may pass, you've taken this test before and fail, or this is your first time taking it. There's a key thing you need to focus on when you study this exam for exams. The specific things you need to know. So this is just to help you focus on your studying and how to tackle the exams. I think the whole exams is based on pathophysiology. So, um, but in order to do well in the NCLEX, you should you should you should focus on clinical judgment. You can learn your content. Okay, you can learn your content, but if you don't apply clinical judgment to content, it becomes a problem. Your whole test is based on clinical judgment, and it goes either way. To be able to pass the NCLEX exams, you should have a good clinical judgment. What does that mean, clinical judgment? You study and then you apply it. Remember, the NCLEX exams is usually asked in there's five type of question. There's just a knowledge based on that disease process. They ask you if you know it, you know it. If you don't, you don't. Then there is a prioritization question. And then there is a SATA question, which is involve signs and symptoms, education, knowledge-based intervention. There is a application level question, and there is a critical level question. The critical levels questions and application are what usually give you a passing level question. So as you study for exams, I want you to pay attention to that. Don't just study content, but study in such a way that you're trying to pass these exams and focus on clinical judgment. If you have a good clinical judgment, well, then your practice will improve. And therefore, to pass the NCLEX, you need a clinical judgment. And when your clinical judgment improved, clinical practice. Clinical practice is based on the analytical questions and the application questions and critical thinking questions. So don't just study the content, but know that as you study the content, you keep on asking yourself, why? Why all the time? And how the why answer, we will talk about it. What do you mean by why? And that when you start asking why, you're thinking critically. So what is the clinical judgment? Well, clinical judgment will improve your communication. So if you know the content and you apply your clinical judgment of that content, you'll be able to communicate with providers. You'll be able to communicate with your patient and intervene when they're doing something wrong. And with that content, you can make a diagnosis. For example, if somebody comes with right lower quadrant pain, nausea, vomit, low-grade fever, urinary symptoms, and vomit, like I already said it. You can put these together and say, what are these signs and symptoms? I can make a diagnosis with it. Sometimes all the signs and symptoms doesn't make sense. You need to pick a few of them to make educated diagnosis. And then you can say, oh, this is maybe appendicitis. So critically, you thinking, you're not memorizing those information, but you are applying it. And after you make that diagnosis, you can make a decision about that problem. So you know it's appendicitis, where the decision for me to check the VBC, check UA, and maybe get a CT scan to make sure I'm confirming my diagnosis. And then if it's a female, I need to get a pregnancy test to rule out ectopic pregnancy. So I'm applying all those information without not memorizing anything at all. And if The clinical judgment develops through what? You develop that clinical judgment, you develop it through by improving your practice. Okay, you improve your practice, and then out of that practice, you become more experienced, and experience become knowledge. That's the case here: knowledge, skill, and then ability, and that help you analyze things critically. So all this thing is interconnected. They are not separate, and you got to pay attention when you study. That critical judgment, what happened? It extends to diagnosis, and we already talked about it, therapy, communication, and decision making in the future. And this is what the next gen question is about. So I try to teach, when I teach in such a way that you can even use this information to answer next gen questions. So whatever they just change it, the kind of form of questions, but the content and application is the same. They now want you to think critically to improve your clinical practice. That is what these next gen questions are going to base on. And they're doing it now, even right now, the same thing. If you practice it, it can help you right now in your exams. And so when you're studying for these recent NCLEX exams, pay attention for critical knowledge, understanding, and application instead of memorizing. So how do you improve your critical judgment? It's your content. But content in what form? Pathophysiology. You're not studying content, but you're studying this, pathophysiology. I'm a pathophysiology guy, and this is the why question. Every time I'm looking for a disease process, I'm looking for the pathophysiology, and I can use it to educate the patient, analyze a patient, prioritize the patient, and the content knowledge questions easily. And so pathophysiology of the disease is the key thing you should focus on. And that's how you can think critically. So let me give you an illustration about this problem, how you can. So I'm going to use DKA as an example to show you how content through pathophysiology base can help you think critically. This is our cell. Okay, this is a cell. This is inside the cell. This is outside the cell. So extracellular. So these are all your extracellular fluid. Insulin is produced from the pancreas. And the main function of insulin is to push glucose inside the cell so that your body can use insulin. It can use glucose. It also pushes potassium inside the cell and also push water inside the cell. So water, due to glucose, as glucose moves, water moves with it. Therefore, insulin. So insulin is needed for glucose metabolism. If your body does not have insulin, like type 1 diabetes, well, they cannot use glucose without insulin. So they inject themselves with insulin, exogenous insulin. So that's why they have insulin injections and daily for their normal function. If the body cannot use, there's no insulin available, they can use glucose. So what happens? They use other form of macromolecule. And the common one they use is fat. Sometimes they use protein. This is the same when you're starving, you fasting, you're not eating, your body start to break down fat. And fat, when fat break down, they form ketones. And these ketones lead to ketoacidosis. Ketoacidosis. So you expect diabetic patient to have ketoacidosis if they don't have insulin to break down their glucose. So this is what happened. They develop ketoacidosis. And how did this develop? When diabetic patient, type 1 patient, they sick, well, they don't want to eat. So that's the sick day. They don't want to eat. So sick day, no food. They don't want to drink. And then they will tell themselves, well, if I'm not eating and I'm not drinking, then I'm not going to take my insulin. So they don't take their insulin. What happened? Their glucose build up. So more glucose. They keep on increasing and their sugar can go over 250. You get to that level and the body doesn't like it. They're not eating, they're not drinking, high glucose, they're not taking insulin. High level of glucose will get rid of fluid. Water will follow it. So what will happen? You get osmotic diuresis. So they just pee all the fluid out due to glucose. And their urine output increase. And what happens? They get dehydrated. And they can go into shock from hypovolemic shock. Right? They don't have insulin, so they cannot push potassium inside the cell. So potassium goes up, hyperkalemia, initially before you start trading it. And this hyperkalemia, if you look at my priority questions, prioritization video, this is one of the B sharps, the electrolyte. It can cause cardiac arrhythmia. So for DKA, the main complication is shock, hypovolemic shock, and arrhythmia, cardiac arrhythmia. These are the two things you should focus on. So on the sick days, you got to educate them. Even though you're not eating, well, you should do what? Continue taking the insulin, check your finger stick more often, but adjust your insulin level based on your sugar stick, finger sticks, and drink, hydrate yourself because you're going to get dehydrated. The other thing that will happen, they are form ketoacidosis. And because it's due to diabetic, high glucose causing, and the high glucose and the use of fat to cause ketoacidosis. This is a metabolic acidosis because you're making acid. And then if I'll do an acid-based video, every time you have a metabolic acidosis or you have a form of a change in acid-base problem, the way to correct it is the opposite of what you have. If you have metabolic, you control it with respiratory. And you have acidosis, it has to be alkalosis. So the way to correct metabolic acidosis is to use respiratory alkalosis. So what will happen to this patient? In order to do respiratory alkalosis, they have what we call rapid, deep breathing. This is the Kushma breathing. That's when you see they give you Kushma breathing that you see. It's a rapid, deep breathing to decrease their CO2, PCO2. That is how they can lead to respiratory alkalosis. And then when you smell them, their breath, you smell ketone. So they smell like fruity smell. You see how this is all related to pathophysiology of the disease. So based on that, we know what is happening. In early DKA, their glucose is what? High glucose. They have what? high potassium. They have what? Dehydration. They can go into shock, right? So my pathophysiology has told me this, and they have made what? Ketones. They are in ketoacidosis. So I can treat them based on the pathophysiology. This is application level. What is my priority diagnosis? So what is going to be my priority diagnosis? Well, this is how you can do that. You've known, now you know what it is. Your medical knowledge have given you the problem. They have DKA. What body system is affected? Where is the kidney is affected, the cardiac can be affected, the whole intravascular system is affected. So I know what kind of signs and symptoms they're going to have. So let's do the signs and symptoms. I know based on the pathophysiology, I have to see them Cushman breathing. They're going to be dehydrated. So what would I see? Well, dry mucous membrane. Their blood pressure may be low. They will be cold. Skin will be cold because they dry. So all the symptoms, you should expect that. Okay, they will be lethargic if they dry. Their urine output will do what? Increase because of the glucose. Even though they dry, the glucose is driving. So this is urine output increase from osmotic diuresis. So that's what is causing them. And by intravascularly, they are in trouble. So you see, I'm doing signs and symptoms. They will have abdominal pain from all the dehydration and then glucose level and the other symptoms. And all is they can go into cardiac arrhythmia from high potassium. So what should be my assessment priority? You see, they can ask you what is our assessment priority? Which one is the priority for me? Well, I got to make sure they are not going to cardiac arrhythmia, and I want to make sure they don't have hypovolemic shock. Those two are my priority. So they can have to ask you a priority question on that. Okay? And then they can also ask you expected finding. We already talked about it. What is expected lab values or finding? Well, I expect their CO2 to be low. I expect their bicarb, okay, because they are in acidosis, should be less than 18 because this is being chewed by the acid that is being formed, the ketone, okay? And I expect them to be in their pH. What do you think the pH will be doing? Well, it will be less than 7.3 because it's an acidosis. So I'm using, so when you see this is the expected finding in the answer choice. I know the pathophysiology, they won't be my priority. But if I see potassium that high, early phase, then I'm worried. Now, if you start treating them now, now this is the cell. They come into the hospital, I give them insulin. Now you're giving them insulin. Insulin will push the glucose inside. Insulin will push what? The potassium inside the cell. Then insulin will put water will follow because of the glucose. Okay, because of this, in initial treatment of diabetes patient, the first thing is IV fluid. Because if you give them insulin first, It will drive water and glucose inside, and they become more hypoglycemic. So I know I have to give them fluid first before insulin, because I don't want to worsen their shock, their dehydration. If you give them insulin first before fluid, it will push all the fluid and glucose inside the cell. So they will become more dehydrated. So I give them a fluid first before that. Now, because I've given them insulin, look at what potassium is doing. Now it's going down. So potassium is going down. They will become hypokalemic. This is very important. When you're treating a patient with the DKA, you should replace their potassium, even if it's normal. Even if it's 3.5 to 5, you should still give them potassium. Give them potassium as you start. After you've given them fluid, so you give them fluid, insulin, the next thing you should do is potassium, because their potassium will go down. And hypokalemic, which is part of my B sharp, is electrolyte that also causes cardiac arrhythmia. So these are my priority issue. My priority treatment is IV fluid. My intervention is low potassium if I have to make sure I prevent that. You see what is going on. The other thing too is glucose is going to go what? Down. I know their glucose was already high, greater than 250, and you're trying to give them insulin, but what happened? Insulin will drive all their glucose and they will become hypoglycemia, which is part of my D sharp. So you want to prevent hypoglycemia. How do you prevent that? As soon as their glucose you start giving them insulin, watch their finger stick. If their glucose is less than 250, as soon as it gets to 250, or between 200 to 250, you should start giving them glucose, and you give them D5W so that they won't become hypoglycemic. And you see what I've done? Pathophysiology, able to make a content level treatment, able to make, I can answer SATA question easily. I can do critical thinking. I can do priority intervention. I can manage this patient. And the question they will ask you, DKA, they always ask, what is the first intervention? Is IV fluid, because I know that priority, that a problem is I want to prevent dehydration followed by cardiac arrhythmia. And that's how you can do well in your NCLEX, trying to put everything together such that your content level, improving your clinical judgment, which will improve your clinical practice. And how is this related? Well, pathophysiology. So all my videos, I will mention this, pathophysiology. If you know your pathophysiology, there's no question that can beat you, because you know how to apply it. You just not memorizing it. You're trying to find it. Why will you have DKA? Why is there something called DKA? Why is something called asthma attack? Why is something called hyperosmolar hyperglycemic state, HHS? Why do you have to be careful when somebody has asthma? You got to be careful you don't give them beta blocker. Not just beta blocker, you got to know that in the lung, there's different receptors there's beta receptor, and in the heart, there's beta receptor. In the lung, there's something we call beta 2 receptor. In the heart, there's beta 1 receptor. So there's 2 beta receptors. So if you give a beta blocker, It can block beta 2 and beta 1. So somebody with asthma, you can give them beta blocker, but you have to know which kind of beta blocker they want to use. You got to know what kind of receptors are on the lung. So you select your beta blocker based on how it's going to function, and that is the pathophysiology. So you give them selective beta blocker, which is BAM. Those are the bismol, atenolol, and metoprolol. They can get beta blocker, but you got to find out which one you can give them so that it doesn't affect them. They go push them in bronchospasm. That is application of pathophysiology. If you know that, when they give you answer choices, now which of these medication is safe in asthma, they will give you a bunch of beta blocker. You know that if it's BAM, atenolol, metoprolol, and bisterol, none of them will cause problem except if it's nadolol or propranolol. Propranolol and nadolol are non-selective beta blocker, and you cannot use it in asthma patient. So this is how you can connect. And when you study, start thinking like that, and that will help you. I hope you're doing well and you keep charging. Good luck in your exams.